Good afternoon, everyone. Councillors, members of the public, officers. Welcome to the first Health and Wellbeing Overview and Scrutiny Committee of the new council. And I believe we have 4 brand new members looking around and 3 existing members, including myself. I'm Georgina Hill and I chair this committee. It is, in my opinion, the best committee in the council, so you've chosen well. Just to go through the agenda, so the first item is the membership, and you will see the list of all the members. I don't think there's any errors in that, anything anyone wants to rate, so we're happy to note the membership. Thank you. Second item on the agenda is apologies for absence.
Chair, apologies from Councillor Sim.
I seem to remember Vicky Oakley put apologies in. I've sent an email after, so if we can put down Councillor Oakley's apologies as well. Item 3 is the minutes of the last meeting. That's page 11 to 16. This comes up and even if you're not on the committee, you can still approve the minutes, but it is preferable to have a proposer and seconder from existing members. So Councillor Hunter proposed. I'm looking at to second the minutes of the last meeting.
I wasn't on the committee, I think I was at the last meeting.
Right. Great. Are those minutes agreed then? I'll take that as agreed. Thank you very much. Item number 4, probably rare in a committee this type, but it's a standing item. Does anyone have any interest that they need to declare? None? No. Thank you. So now to the first substantive item on the agenda. That's the Primary Care Applications Working Group. Rebecca, do you want to just explain that particular group?
Yeah, so the Primary Care Application Working Group is more of an ad hoc group. We don't meet regularly. It's only when needed if primary care has anything substantive that they need to run past us. The membership includes the chair and vice chair and 2 nominations from this committee as well.
Myself and Councillor Jones are automatically on this group as the chair and vice chair, and we're looking for 2 other members who don't need to be members that are in attendance today. But do I have any nominations for other members of the Primary Care Applications Working Group? Councillor Hunter?
I've been on that committee before and I'm happy to go on that committee again if members are happy.
Happy to second that. Is everyone happy that Councillor Hunter is one of our members? Agreed? No dissent? So Councillor Hunter. And we have 1 other member. We've got 1 extra place in the Primary Care Applications Working Group. So do I have any volunteers? Councillor Smith? Yes. Happy to second that. Is everyone happy for Councillor Smith to join? Agreed. So that's our membership of the Primary Care Applications Working Group. Item number 6, this is an item to note. This is the Health and Wellbeing Board. Obviously there's some crossover with the work that we do, so we should always note their activity. We have the minutes. Does anyone have any questions or points on that? Are we happy to note those minutes? Agreed. Thank you. Now, item number 7 is an overview of adult services, a huge area of the council's work, and Neil Bradley, who is our Director of Adult Services, has agreed to come and give us an overview of adult services. I think a really useful presentation for us to receive. So over to you, Neil.
Thank you, Chair. Are we able to bring the presentation up? Okay, lovely. It'd be wonderful at the inception of a fresh committee to get a chance to talk to you and just give a bit of an overview of adult services. I was aware we had some new members in the committee, but this may feel like familiar territory to some of you who've been involved in health and social care for quite some time. But I'm just going to give in the first part a bit of an overview of the sort of size, scale and what we do, just to make sure everybody's knowledge base is in the same area. And then towards the latter part of the presentation, I'll talk a little bit about what's hot in our arena at the minute and what the teams are focusing on and what we think is coming up on the agenda that may well prompt some work that you want to bring through the scrutiny committee going forward. The first slide I've put up here is just some big numbers to give an idea of size and scale. So, I mean, bottom left corner there, we fluctuate between about 5,000 to 7,000 clients that we deal with at any point in time in adult social care. That number has come down a bit unusually in the last couple of years. You would expect it to grow with an ageing population in Northumberland, but I will explain some of the things that we've been doing and some of the change in focus that we've had within the service that has actually led to the number coming down, but it's still a significant portion of the residents of Northumberland that interact with adult care because they have some form of need, disability, frailty, etc. Top right corner there, second one down, we interact with more than 22,000 people per year in terms of information, advice and support. So there is a huge flow. That's 22,000 separate people approaching adult social care in one form or another. Clearly not all of them go on to have services here, but some will move into the sort of 5,000 to 7,000 number in the bottom corner. Our one call receives 900 calls a day. It does cover adults and children's that, so we pick up children's calls as well, but significant flow of work. And our bottom right corner there, joint equipment loan service delivers more than 1,000 pieces of equipment each week. Again, I won't go through all of these. I'm just trying to give a flavour that it's a huge operation that's ongoing here in Northumberland, as with every other local authority, and a significant proportion of the council's business that we're picking up. We are statutory. We are steeped in legislation for adult social care. The top line there has the Care Act 2014. That's the primary bit of legislation that dictates what I have to do. I'm in a statutory post. A local authority has to have a Director of Adult Social Services, as they have to have a Director of Children's Services. That sets out the context of how we must assess people who present with needs for adult services. It sets the context of how we are required to support them if they pass a threshold for need and services with us. It also places requirements on me to have a sustainable market for care in Northumberland. It puts statutory requirements on me around delivering safeguarding in the context of adults in Northumberland. So we're frameworked around statutory legislation. This is not an optional thing for the council. You know, when you come to cutting budgets and things like that, you can't stop doing adult social care. You're required in law to do it. The other pieces of legislation there that we also use, but are used by other parts of the health system as well. So the Mental Capacity Act sets out how we need to interact with people who can't make their own decisions, who've lost capacity for whatever reason. The Mental Health Act, you'll all have heard of people being sectioned under the Mental Health Act. That is the legislation that allows the NHS particularly, but we support that process to detain people and then release them from detention as well. And then at the bottom, we've got the Health and Care Act 2022, which actually brought back the power for the government to inspect us as adult social care departments. We've had a long, barren period without inspection since the mid-noughties, but that came back in, and I will touch on that later in the presentation as well. That's not an exhaustive list. We are governed by other pieces of legislation as well. For example, there's parts of the Housing Act that dictate how we have to handle disabled facilities grants and things like that. I can dig into more detail with that with members if they had any specific queries, but this is a kind of a light skip through today just to set the background and tone. A lot of people, when they think of adult social care, think of care homes and domiciliary care services. So I've just put a sweep there, and I literally brainstormed that 2 weeks ago when I put the presentation together in about 5 minutes of some of the areas that we interact with. So it won't be exhaustive, but I mean, a lot of advice and guidance that doesn't lead to service provision in the end. I mean, down near the bottom of the left-hand side, there's direct payments there as well as direct provision. That's where we give people money instead of a service and allow them to manage their own care services, in essence, supported by our teams. And if you go down the right-hand side, we've got charging and financial assessment. One of the key differences between us and the health system is that healthcare is free at source. In this country, adult social care is not free at source. You are means tested for your ability to pay. And there are two sets of rules, one if you're in a care home and a slightly different set of rules if you're receiving care in your own home. But at the minute, we collect £41 million worth of income from charging for adult social care, which makes our income budget bigger than most of the parts of the council's expenditure budgets. But I'll come on to finance again a little bit later as well. We give financial and benefit advice, and near the bottom actually as well, just to point out deputyship and appointeeship. We will have people in the community that do not have family or friends or people that can support them when they lose capacity to manage their finances. So we will step in as a financial parent, and we have between 700 to 800 people at any point in time that we're managing their money basically, and that will include selling their properties if we need to, if they're going into a care provision. We actually have one lady with millions of pounds worth of assets. We're still searching through accounts in Hong Kong to try and find all of her money, etc. I mean, it becomes an incredibly complex area of work for our teams, you know, from people on relatively low income up to multi-millionaires who hit the system with no family members to support them at all. It's a very interesting area of work, I have to say. I've probably come across as quite passionate. I wouldn't work anywhere else these days. I haven't done adult social care. Performance. We do really well on performance, I'm pleased to say. We, in the overall rankings of ASCOF indicators for user surveys, which are kind of, we think, one of the best metrics for trying to understand where you pitch, because this is what carers and users of surveys have said about us as an organisation. We are ranked above the North East England averages in 12 out of the 21 indicators, and for 11 of those we're in the top 25% of the country as well. There are only 2 that we are outside of the averages for the UK. That is for a number of people with direct payments, and I will come on to direct payments in a bit. And the other one is proportion of people who are offered reablement following a discharge from hospital. And I have to say we're nudging our health colleagues on that one because we want to see what data they've submitted, because we normally do quite well on that, so we're not sure why that's dropped this year. But overall, we do really, really well out of this. Just for a little bit more detail on the performance, particularly in the carers survey, there's 5 indicators in there. So there's 153 local authorities with adult social care responsibilities. On carer reported quality of life, we came 3rd in the entire country. And on proportion of carers who reported they had as much social contact as they would like, we came 1st in the country for those particular ones. And we've done that consistently over another. It's a biannual survey, and for a number of years we've come up ranked really highly with that. We're not perfect. I would never pretend to admit that. There are things we want to improve, but when you compare us to other local authorities regionally and nationally, we stack up really well in performance terms, and that was recognised by CQC when they came in as well. For finance, we're big, we're really big. So we spend nearly half the council's overall net revenue budget at 150 million through adult services. Children's is the next biggest behind us, and then local services. But in gross terms, you can see from that diagram, from that narrative there, we spent 265 million in total, with a gross commissioning budget of 176 million. So what that says is most of the service provision we're doing now, we're buying in. We don't do direct, we'll come on to some direct provision later in the presentation, but predominantly we're buying from the independent sector the bulk of the care that we're delivering. So care homes, home care, daycare, etc., supported living, mainly the sector's delivering it for us, which is why it's so important that we manage those markets really well. We do manage £65 million worth of health's money on their behalf. So health, where they deal with continuing health care and free nursing care. And again, there's always a lot of acronyms in adult social care and health, so I apologise for that, but people stop me if any of this is completely alien concept. But continuing health care is broadly where your needs become so severe that you are categorised as having a primary health need rather than a primary social care need. But in reality, you could be in the next bed in the care home to that person. So we're dealing in the same industry as health and social care there. So years ago, we set up a partnership with health. It made much more sense for us to do it together. So we do it on behalf of health, and we commission, we case manage, we pay the financial bills, etc. We performance manage for health, £65 million worth of their spend for them. I've already mentioned the income from charges there, and just as a note, the savings target for adults this year is 3.6 million that we're trying to get out. What is working well? I'm not going to go through every line of this again. I mean, I'll let you cast your eye down as I'm talking about it, but just to pick out some highlights. We have just gone through a fundamental transformation of the frontline teams in adult social care. So this is the social workers and care managers that are the main point of interaction with clients when they approach us. We previously had a model that was split between what we called care and support and mental health. So if you approached us with a mental health issue, you went to one set of social workers. If you approached us with a kind of a frailty, an older person's a physical disability issue, you went to another set of social workers. And what we found was there was really a Berlin Wall coming up internally between those two sets of staff, and clients were getting bounced back and forwards. So if there was some sort of mental health issue starting to arise with somebody who was predominantly physically disabled, the physically disabled team was trying to push them across to the mental health team, and the mental health team was saying, no, they're not ill enough mentally to come across to our side. That's not what we want. We don't want the client a ping-pong ball in the middle of our team. So we restructured last year, fundamental change. We've merged mental health and care and support together, so we don't have a Berlin Wall. But we took the opportunity to move to a prevention model at that point, where we set up hubs at the front of adult social care. So almost everybody that comes into adult social care will go through a prevention hub first, a front door for us that will work as hard as they possibly can in a short period to rehabilitate them to be as independent as possible. This has had quite a crazy level of success beyond anything we expected. When I was mentioning at the start that the numbers of clients that we've got overall in the system have dropped, it's entirely due to this prevention hub. And in 1 year, remember, we only started with pilots partway through last year, so we haven't run with a full year of this new model yet. We've, in essence, reduced our net population by 1,000 of adult social care clients through that. And that is predominantly a lot of OT work, a lot of rehab work, a lot of signposting out to other things, and levels of independence, so that people haven't needed to come into the long-term part of our system to get a dollop of home care, a bit of daycare, or to go into a residential or nursing care home. That is a huge success for us. I mean, the government is pushing us. We want people to remain as independent as possible for as long as they can. When you go into a care home, in essence, your life as you knew it ends at that point. You know, it's actually very reassuring for families, I have to say, you know, to have a lot of staff around somebody. And we often get a big push from families, if people have tried a care home out, to stay in there. But from our perspective and from the client's perspective, you will lose your network of friends. You won't ever have the social interaction that you did before. It is a juncture and a move to a complete change in lifestyle that we'd rather put off as long as we possibly can. So we split the teams into a prevention front end and then long-term teams for those people that ultimately do need services. There will always be a cohort of people that are so frail, etc., that they need a domiciliary care service going in there, or they need to go into a care home. So we've got a set of the team that's dealing with that, and another set that is completely focused on rehabilitation and independence. The staff are loving it, I have to say. The staff that work in the frontline service are finding it a much more energised, problem-solving type environment. And the ones that are in the long-term part of it can really focus in on the clients that have ended up long-term, as opposed to staff flitting between duty at the front end and then trying to give the time and attention to people long-term at the back end. So, roaring success at the minute. We're still in the infancy of it and watching it, but it looks like it's sending out all the right messages at this point in time. Also, what is working well, our MASH is regionally and nationally recognised. We still get other local authorities coming up to have a look at our multi-agency safeguarding hub. We were the only one in the North East for a long period of time that had CNTW, the Mental Health Trust, having a permanent member of staff in the MASH, which was absolutely invaluable to have that crisis mental health expertise in there as high-risk cases were coming in the front door. There are 2 other authorities now that have got CNTW in their MASH, arguing that Northumberland has it, so why can't we have it as well, in essence. So, but we've had it in for a long period of time. And the last bit, as I say, I won't go through everything. I was just going to touch on 3 and 4 there together. So we still have really, really good working relationships with health. I mean, some of you might be aware that we were a full care trust with health up until 3 years ago. But we split at that point for a variety of complicated reasons that I don't propose to go into now. But we've held on to the best bits of our integration with health, particularly hospital-based teams. So all of our staff that are associated with hospital discharge work in the hospital itself. They don't work from adult social care bases. They're given space in NSEC. They've got space in Wandsbek General Hospital, Hexham General Hospital, etc. And it works wonders that when the hospital is under pressure, they can walk the wards with the consultants and the nurses and get in really fast on the ground around discharge. Not everything's perfect all the time, but it's a massive head start on what other local authorities have got that don't have that model operating. And again, our delayed discharge performance is really, really good regionally. And this region does better than most nationally. I mean, you might have seen in the press, London's having an awful time around hospital blockages and things like that, as are some other parts of the country, but we do really well on it. I mean, still tricky, but we do really well on it comparatively up here in the North East. Within commission and performance, again, just a slide for you to cast your eyes down. I mean, generally we run a really tight ship around contracts and managing the market. Some people may be aware, I mean, about halfway down there, I've got positive provider relationships on the whole. We do have a relatively small and quite militant rare set of representatives from the care home sector who, you know, there is a little bit of, we try to work as positively can with it, but, you know, we have ended up in court on one or 2 occasions with GRs and things like that. But overall, the relationships are really positive with the sectors. And we are trying to work with them as best we can to get the best possible outcomes for clients from that. We have strong governance arrangements in adult social care. It comes from us being part of health, I have to be honest. You know, I mean, the health sector is really, really tight on governance. We only came out of there 3 years ago, and we've carried a lot of that into the way that we've rebuilt our governance models from when we split from health 3 years ago. And our relationships, again, I've mentioned with the ICB, there are really good. Remember, the ICB is a commissioner as well. We are a key commissioner in Northumberland. The ICB is a key commissioner, and we work hand in glove with them on what we're trying to achieve. But a tight ship around commissioning and performance and trying to build really positive relationships with providers on the whole. We have to have a principal social worker. That is a statutory thing that's set down in the Care Act. You're not allowed to not have a principal social worker as the lead for your professional workforce. We're big on audit and quality within social work. We're big on professional development for staff. And we set up 2.5 years ago a social work academy that's had recognition. We've had it independently reviewed, and it got national recognition as well for the academy and the model that we'd operated. So again, very proud of that when I'm talking about what's working well within adult social care at the minute. And then I mentioned in-house provider services. We don't have many now. Most of them were sold off through, externalised through the 90s and into the early noughties, but we still have some for learning disabilities. So we have Tynedale House in Blythe, which is a residential home. We have some smaller scale specialist LD provisions for 1 or 2 clients with challenging behaviour. And then we still have a swathe across the county of learning disability day centres and some horticultural units as well. The key thing to say about this is they're all CQC rated good or outstanding at this point in time. We have a passionate and committed workforce. I mean, I still get around to see them quite regularly, and I get that lovely warm feeling inside whenever you go in, you see how much the staff and the clients are interacting, and it's just a very positive environment. I have to say nationally now, and what we're looking at this point as well, is there are certain parts of the market that are becoming almost too expensive for us to buy from at the minute, as it is for children's services. I mean, it's the SEND agenda in children's services, looked after children's. We know the costs are escalating to an exponential degree. That is starting to happen in adult services at the minute. So we have got half an eye on whether we might actually want to internalise some things again to get more control over price and what's actually happening in Northumberland. So that is on the agenda, and we're looking at it, at what projects might be viable to go forward. We were CQC assessed last year. We received a good rating with a score of 70. At the time, it was, I think we were about top 3 in the country. Obviously, there's been a lot more since then. We're still the 11th highest score in the country. There has been 1 rated outstanding now, which was Camden in London, 29 rated good, and 17 rated requires improvement. And the numbers are still coming through thick and fast. So it's almost every week there's another set of publications from CQC at the minute. Everybody in the North East has had an inspection now, but not everybody's results have been published at this point in time. I think about 2/3 of them are out there. So we've still got an interested eye to see how our colleagues are doing in other neighbouring local authorities. But yeah, interesting. I mean, CQC for us, an awful lot of positives. I mean, we were praised for our partnership work, and in particular the word excellent was used in the narrative, although we didn't get a score based around outstanding. But I think the phraseology was used in the report. The areas that we were told we needed to improve on were not a surprise. So support to unpaid carers was something we knew was a direction of travel that we need to do more with, and we have started to do more with it. Co-production, and you're getting a presentation from my health watch in a minute after me, and Derry and her team have been really helpful for us in starting to produce better forums for us to do co-production with people with lived experience, etc. We have a forum that runs every month, I think it is, isn't it, Derry, now, where we run a number of agenda items through people with lived experience to get their views before we develop things. And a few other slightly more technical issues that they picked up, but there wasn't a lot in there, and certainly nothing that we weren't cited on already, which was good because we had action plans in place for most of it, and it's just continuations of those. Okay, current areas of focus. I've kind of described the first one, the prevention model. The only bit I'll add there is it is heavily linked into Jill O'Neill's public health work on Communities First as well. So when we've got people coming to the front door, we are using our OTs, we're using our rehab services, but we're also looking at opportunities to signpost into the voluntary sector as well for support. You know, again, it's trying to get people involved in their communities and trying to get people involved in projects that make them feel they're giving back, particularly people with low-level mental health issues and things like that, where a prescribed service isn't necessarily the best thing. You want people to have some value in their life again and what they're trying to do, and a link up with community projects can be a really, really good way to do that. The halfway down there, I've got changes in the NHS. I do want to come back to that right at the end and just give you a little bit more detail on that one. But I mean, you can't have failed to have seen in the news the huge changes that are happening in the NHS at the minute, with ICBs having to take 50% cuts in running costs, etc., and things like that. So I will touch on that at the end. And the pressures on acute trusts I've mentioned there. Although we do really, really well around hospital discharge, I make no bones about it. I've never known anything like the last 2 years in terms of hospitals. And yeah, you'll have seen headlines around beds in corridors in A&E and things like that. That used to just be a winter thing for a short period in the winter. We are seeing that spike at multiple points during the year now and running for much longer periods of time where they're under really, really significant pressure. And I mean, this is health and well-being scrutiny, so it might well be something that we want to bring back here to have a chat with the trust about, etc., and have a little look at where that's at. Just a few more on the current areas of focus. We are going to have a look. It's a long time since we've reviewed our joint equipment loan service, the second one down there, the GELS review. That is a 50-50 joint funded service with the ICB. The ICB are facing a lot of cost pressures at the minute. We haven't looked at that for quite a while, so we're going to do a fundamental review with the ICB on that service and whether it's pitched at the right level and the right places now. The one below that, developing new extra care and supported housing, is a huge theme for us at the minute. We do have an ageing population in Northumberland, and we have a growing number of people who are presenting with complex needs, people under 65 with learning disability and mental health needs, etc. And we need to get the accommodation solutions right for them right across the county. So we have a huge programme of work that we're trying to take forward, in reality over the next 10-year period, around developing extra care schemes. I mean, Georgina, you and I have spoken a few times about Berwick and us trying to sort something in Berwick, but we're trying to get something literally in every part of Northumberland. It is an aspect of work that people talk about what's the demand like for these areas. It's almost exponential for us at the minute. We can't build fast enough necessarily. It will get eaten up in demand when we get it. The key win for us, if we can get it right, particularly in the market towns, in the more rural west and north, is that it's very, very expensive for us to deliver care out into the most remote parts of our community. It's really, really difficult to get staff to travel all the way out to Allendale or out to Kielder or whatever and things like that. If we can create an attractive enough option to draw people into an extra care type facility, for us to arrange the care around that is so much more efficient and kind of better value for everybody in terms of what we can get. So it's a bit of a win-win if we can get this work. And it's not actually something that's costing the council an awful lot of money. I mean, I do have a small amount of funding to kind of prime some of this, but a lot of it in the more popular areas, housing providers are happy to develop this for us because they'll get the money back through rental anyway in terms of their financial models. So really, really good. And then just the last one down there, replacement of the main client information system. We do operate arguably the second biggest IT system in the council. The biggest one is Oracle, which is the main HR, finance system, etc. Our system was Swift, and we've had it since 2001. I mean, it was literally hamsters running around a mill, to be honest, to keep it going. We turned on the new system last Monday, which is Jesus that we've brought in, which Durham have as well. Fairly new product to the market, which is good because it makes the IT company, I think, quite hungry to work with us in terms of developing it so they can sell it on to others. I'm keeping my fingers crossed. We've got teething problems, but not too many. 4 days in, or 5 working days in. But it has been a huge 2-year project to get to this point, and it will remain a project for the next year as we iron out the gremlins and start to maximise the opportunities of it. So people at the minute in some other parts of the country can interact with adult social care for the first time through a portal, through the website, automated form like you would with a bank or something at the minute. We haven't been able to offer that because our IT system was too out of date. We can start to develop some of those solutions that allow, younger people who are perhaps dealing with parents or whatever, who are very IT savvy, they can interact with us first through an automated web portal rather than having to pick up the phone and talk to social workers necessarily and other people straight from the off. Again, you can cast your eye down and pick up any others if there's queries at the end, but it's not my style to go through every line of a presentation. And then I've come to questions, but if it's all right, just for a tiny bit of indulgence, Chair, I was just going to touch on the health item that I mentioned before. So the NHS's 10-year plan was published a couple of weeks ago. Some of you might have seen some summaries of it or whatever. There are probably 3 things in there that I wanted to draw out that are of particular interest to us in adult social care. The 10-year plan talks about integrated health organisations, or IHOs, which are a reincarnation of something that was actually mooted in the late noughties, but were called accountable care organisations at that point in time. And if they come in, would be a huge change in the way that the NHS runs in this area. What they basically are is usually an acute trust gaining the power to manage most of the resources for the NHS in that area. So you wouldn't necessarily have an ICB sitting managing the money to start with and then doling it out to primary care, some of it out to the acute trust, some of it out to the mental health trust, some of it out to the ambulance service. It would all go to a key core provider, which it would usually be one of the two acute trusts, either the mental health trust or the hospital trust, and they would run the show in there. And that will be a fundamental change and a fundamental interaction for us to handle differently, because a lot of money flows between us and the ICB at the minute, which would then flow between us and the acute trust. So I've got a very interested eye on that, and whether either Northumbria or CNTW would actually pitch to be an IHO in the early phase of them, which I think they're looking to start with applications from next year. I mentioned ICBs a couple of times. ICBs are also mentioned in the 10-year plan, and they are having a fundamental change in their responsibility, in their role. They have to cut nationally they have to cut their budgets by half. In actual fact, in the North East, it's not quite half. I think it's about a third they're having to cut by here, because they're already deemed a more efficient ICB than some other parts of the country. But again, that's going to fundamentally change our relationship and the flow of funding between the local authority and the health sector. What are they going to do with our CHC partnership going forward? Is that going to change? That is a huge thing for us. It's a huge thing for them as well. It might not change at all, but I don't know at the minute. You know, there's a void to be filled here of information. And then the third one that was mentioned in there was neighbourhood health centres. And I mean, the head strapline was, this is a quote from the report, there will be one in every community, beginning with places where healthy life expectancy is the lowest. They will at some point be open 12 hours a day, 6 days a week, and they will convene a diverse mix of professionals. Social care professionals were mentioned in that. Public health services were mentioned in that. But there isn't much in the small print of how that would roll out into a geography like Northumberland's at the minute. There is actually a kind of pseudo version of that in operation in Hartlepool, but Hartlepool is about 5 miles square. It would be very easy to get, something in the centre of Hartlepool that everybody can access. We all know for our geography that will be a really interesting one to see how that unravels and where it's at. But we are named as needing to be a key component in that as it's developed. There was originally intended to be a chapter, there's 8 chapters in the NHS 10-year plan. There was originally intended to be a 9th chapter, which was the delivery plan. And I know that was taken out by ministers at the last minute. It's going to follow a couple of months later. That's the one I would have really liked to read, I have to be honest, and the one I'm really waiting to see what the content is so we know where we're going with it at that point in time. It's probably better if I stop there for questions, Chair, if that's okay. So probably a whistle-stop tour. That's where we're at the minute.
Thank you very much, Neil. And I think, as you mentioned at the beginning, it's an eye-watering amount of money, half the net budget. And we probably, same with all local authorities, we talk disproportionately about other things at much smaller part of the budget, and we should maybe be scrutinising more on this. So if there's any suggestions, things that we can look at in this scrutiny committee, and obviously, but as you've alluded, the evidence is there as well. This service is a good area, quite a strong position in this council. So does anyone have any questions? Yes, I will. So Councillor Davidson and Councillor Hunter.
Thank you. I was just wondering...
You might just pop your microphone on, because it's recorded as well, so it helps people when they're listening back.
Right, is that better? Right. Sorry, Pauline Davidson. I'm councillor for Amble West and Warkworth. Yeah, I was just wondering how the mental health crisis team fit into this, bearing in mind that mental health issues have rocketed over the past months, years. And how are the teams coping with that? Because I know how difficult it is to get help from them.
Yeah, the mental health crisis team is CNTW's, so it isn't ours. It's the Acute Mental Health Trust's team. But we work hand in glove with them.
Yeah.
So out of hours, etc. So we have AMPs, allied mental health practitioners, who will go out with the crisis team to section if they need to, out of hours and things like that. But basically, the two teams work really close together is the bottom line to it. But that's ultimately theirs. It's not ours as a statutory function, as a team that delivers it. It's an area that's been growing an issue. I mean, actually, particularly people with drug and alcohol problems as well within the mental health structure. So, I mean, we've done two things within the last couple of years, one more recently. One, we've created dedicated staff for drug and alcohol issues. So we've got a drug and alcohol service in adults now with a couple of specialists with a lot of experience who work closely into very, very difficult cases in that area. And then more specifically around people with severe mental illness, we've, and this is one of the wonderful things about breaking, I mean, I'll come back to that in a second about relationships with trusts and things like that, but the punchline is we've created a severe mental illness team that is co-locating and co-working with CNTW's mental health teams as well, including the crisis team, to try and integrate much better in terms of the solutions and the support that we can give to people. I mean, I have to say, having been part of the Acute Trust for nearly 10 years, when we were in the latter part of the partnership, we were actually, I was an employee of Northumbria Acute Trust running adult social care, because that was the nature of the partnership that we had. I hadn't realised quite how it can be difficult for NHS organisations with competing needs and competing powers. So we had very, very close integrated working relationships with mental health services through the 90s and into the noughties. When we ended up being, in essence, becoming part of the Acute Trust, not the Mental Health Trust at that point in time, it fragmented our relationships from a mental health point of view, which was a shame, because we had some of the best ones operating in the country. But I think that the trusts do rub up against each other a little bit sometimes. You know, best intentions aside, you know, in terms of where we were at. And only now that we've come apart from the Acute Trust have we been able to have really good relationships with the Acute Trust, but start to rebuild really good integrated working relationships with the Mental Health Trust as well. So I think we've never been in a stronger position as adult social care. You know, I think it's a shame what happened 3 years ago, but ultimately it's left us in a really strong position to get the best out of every relationship, rather than being in some of the small politics of the NHS, which can happen at times, you know. So, but yeah, so really, really positive, but absolutely one of the most difficult areas we deal with. Yeah. That's why we've created this much closer integrated work and with CNTW on that, and really, really pleased that they've been open to that.
Thank you.
Yeah.
Councillor Hunter?
Yes, thank you, Chair. Thank you for the presentation, Neil. That was very interesting, as they usually are. My question's on the telecare and the switching over to the digital broadband, because there's many different elderly or disabled people, there's many different facilities in their houses, and are we working through that to support them? Because it's all right, the ones that comes to contact us or that your team picks up, but it's the ones that don't contact maybe till it's too late, and then they go, what do we do?
So certainly all the people for them, we've been proactive. Sorry, I should turn that back on. We've been quite proactive with that. So they have all been contacted. They've all been talked to. I mean, the big thing in the press has been what happens when you get a power cut, you know, and all of that. So we have gone through contingency arrangements with people and provided them with information and leaflets, and we've got workarounds at our end. So we know if the power goes down, we can see where we've lost connectivity, and we have contingency arrangements that we would, I mean, ultimately it would come to us sending somebody out there to check they were okay and that they had some form of interaction available to them. I mean, most power outages are fairly short term anyway, unless you're in a Storm Arwen type situation or whatever. So yes, it's in hand. I don't think you can ever turn around and say you could account for every single contingency, but I mean, even under the old analogue system, you still could have had your telephone lines cut or whatever and ultimately been out of power, and we would have had to get a workaround. There's always some form of doomsday scenario that could make it really difficult. Storm Arwen was one of them, and that ended up door knocking at that point in time. We would do whatever we needed to do to keep people as safe as we can, is the bottom line. But yes, we've been proactive. Everybody's been contacted. Yeah.
Councillor Carr?
Thank you, Chair. Thank you, Neil, for the presentation. Neil, in terms of the staff who do the frontline services, do they have like a centralised hub in the areas that they cover where they can speak and get to know each other a bit, so there's that interaction rather than them just going out and then going home again?
Yes, absolutely. And I have to say it's something that we switched tactics on a little bit. So post-COVID, in the early days of hybrid working, we had a big push to get people working from home as much as possible. Social care is one of those professions where that didn't work as well as it did in other parts of the council, for the very fact, as you've just described, when you get a complex case, particularly with a more inexperienced member of staff, they need to rub off a more experienced member of staff. And to be quite honest, just ringing somebody on Teams or ringing them on the phone, you don't always get an answer, depending on what they're doing. So we're now trying to get staff back into the office at least 3 days a week, if not more. So they're getting that interaction there, they're getting that professional rub off each other. It develops the staff better. It makes them feel more secure as well in terms of the decision making that they're going through. I mean, as you say, some of these decisions that we're making around people with mental illness, you know, they're really tough, challenging things that people are having to make calls, and they want to talk to the team manager about it who's got a lot more experience. Yeah, I mean, the bottom line is we've decided that the full hybrid model doesn't work in this area of work. That's not to say it's horses for courses. Our commissioning teams mainly work from home. You know, they found that works really well for them. They don't need that rub. They can have the kind of group calls on Teams and things like that. But social work, it wasn't working for us. So yeah, more back into the base. Not 100%, because we're conscious of the council's policy around the efficiency on the use of resources, but we need people in to a degree. Thank you.
Thank you very much. Councillor Smith.
Yeah, thank you for that, Frank. It was very interesting and very thorough as well. You mentioned that CQC are the regulatory oversight body. Are you aware that the head of CQC was sacked by West Streeton when they came into government, and that the Department of Health did a very damning review of CQC, basically said they're not fit for purpose? I wonder how much that has changed the CQC inspection and your relationship with them.
There was actually quite a public damnation of CQC 2 weeks before our inspection, actually, which led to, I don't know whether it was a good thing or a bad thing, we actually ended up with the Chief Inspector and the Deputy Chief Inspector on site for the whole of our inspection. I think originally the Chief Inspector was going to come for a day of it, but he ended up, and actually as part of my DAS interview, he was on the panel for my DAS interview, so I felt like I was right in front of the head honcho, to be honest. I thought it would be intimidating to start with, but actually because he's a social worker by, a Director of Adult Services by background, it ended up being a really good conversation with him, actually. It's a tricky one for me to comment on that, I think, isn't it? You know, I mean, I think CQC have been in a difficult position. It's an unenviable job, if I'm honest, trying to find enough resources to do 153 inspections in the timescale that they need to do it, alongside all of their other regulatory duties. I wouldn't have fancied that task from the off, to be honest. I thought it was a big ask for them to try and pull in enough experienced staff to do it. I think they've had a good go at it. I think some bits of it have worked quite well. I think other bits, you know, probably haven't worked as well, and I'm not saying anything there that I don't think they're getting this feedback from other local authorities. I'm not as knowledgeable about what's going on at the very top of that organisation at this point in time. Clearly, it's had quite a bit of turnover. I know the Chief Inspector itself, who we worked with on the inspection here, has changed, although he was only in an interim role with them anyway, obviously loaned out from a local government position. So, but it's... I think they have a really hard job, I have to say, for what they need to do with the resources they've got to do it at the minute. Yeah.
Do we have anyone else? No more questions. This presentation, I believe, is going to be sent out. Yes. And would it be possible for members to inform the casework more, but would it be possible to have a note about signposting? So any issues that come up for us residents, particularly for the new members, just a note about signposting, who to contact if a resident has. I mean, I'm in touch with you most weeks, aren't I, with several times, but it'd just be quite useful for members, just as a general.
You can do. What I would always say, though, in an emergency situation, is one call is the place to go. That would be faster than coming through me, but yes, if it's a time lag, then absolutely.
And just to remind the contact details for one call, I think that'd be useful for new members particularly, and with that presentation, which is really helpful. Thank you very much. Item number 8 is the Health Watch annual report, and obviously Derry will start with a couple of lines about what Health Watch is, I'm sure, for the benefit of the new members. So over to you, Derry.
Thank you very much. Could I have the presentation? Thank you very much. Good afternoon, and thank you as ever for allowing us to present our annual report to the Overview and Scrutiny Committee. I'll explain a little bit more about the function of Health Watch in a moment. I'm Derry Nugent, I'm the project coordinator of Health Watch, Northumberland, and as the chair's just said, I thought it'd probably be useful to start with what is Health Watch. Hopefully you'll have all received a copy of our latest annual report. We have to produce that every year by June, so hopefully you've had time to absorb it. So just a reminder about the formal framework for local health watches. We are a creature of law. We were created in 2012 by the Health and Social Care Act, one of the acts that Neil spoke about earlier. And so because of that, there are things that a local health watch must do by statute. That's the things that we were created to do, and we have to do them, and that we need to show through our annual report that we are actually doing. The 5 things that we have to do that were laid down in law is support public involvement in the development of health and social care services. Now, the thing that changed in 2012 is that before 2012, there's always been a patient voice element to the NHS. If you go back to 1948 all the way through, you know, there's been different words for the same thing, basically. Community health councils was, I think, the one most people knew. And then there were health, then there were links, and then there was Health Watch. The thing that changed in 2012 was that they also gave us social care. So not only did we have the health services, and we mean everything from your GP service, your local chemist, your optician, your dentist, through to all of the acute hospitals, the mental health trust, everything that is under the health service is under the remit of Health Watch. So they then added social care to that, so there's no biggie, just adding on the other bit. But it made sense because those two things are so hand in hand. So our role is to support the public involvement in the development of those and delivery of those services. The point of that is to influence, to improve care. And I think one of the things that I would say first off is that sometimes that influence to improve care can sometimes mean influencing to maintain or not see a deterioration. And I think in the context that we've spoken about in the last probably 10, 15, 20 years, that's been really important. We are also required to provide information and signposting. And this is one of our little known things that people know that Health Watch do. So that is that we are a point of information for people, for the public. And it's something that I think if you look at our report, you'll see is something we take very seriously in Northumberland, because again, it's a complex system. And I think everything that Neil spoke about earlier just goes to that. So where do people find their way in? How do they do this? Where do they find the information? What can they do? And I have to say, it was particularly apposite this morning that I literally, and this is, you can look at my inbox, I came into this email in my inbox this morning. This was from someone I spoke to last week about a problem they were having getting support for their health condition. They felt that they weren't being listened to, and they just felt that they were being pushed from pillar to post. They said, "Thank you for your listening and sympathetic ear. Words cannot express the relief that comes with knowing that there are people out there willing to help and support those who are going through this rather debilitating illness. So rather than having to fight it alone, which I feel I've had to do in the last 5 months." She then goes on to say some nice things about Health Watch. But I think that to me sums up what our information and signposting can do. It gets overlooked, but it's a really important aspect of what we do. We also have to share our insight nationally. So what happens in Northumberland gets fed up into Health Watch England, and then they use that when they are talking to national decision makers. So they take that into Parliament. And I think last year, if you look back at the health committee's debates around, or they were meetings around dentistry, you very strongly saw what Health Watch's influence was. Our national director was able to take what was happening from all over England and actually put that in front, and that's where the National Dental Recovery Plan really came from. And I have to say, we've got 2 councillors in the room today who were very strongly around that, because Berwick was one of the big what they call dental deserts, and I think your tenacity in keeping that on the agenda really did feed up, so that was really helpful. And our final point is that we have to hold agencies to account for their public involvement. So I think everyone in this room will have heard me at countless meetings. My first thing I'll go is, yes, but where's the patient voice? Where's the service user voice? Have you actually spoken to anyone about that? Have you actually asked anyone about that? And that is because that is what we're here to do. So, and I think if you look at some of the things in the annual report, you can see that is where we've really pushed around saying, well, you know, that's all very well, you've made your plans, but actually, let's see what actually people have experienced, and try to do that before you make your plans is usually a better bet. So I've put the golden thread across the bottom of that diagram, because none of this works unless we have experience of people who are using services. That's the bottom line. So unless we hear from people, it's just me talking to Neil saying, you need to change this, which is all very well, but it's not right, and it's not what we're here to do. So the strength of HealthWatch is that it is about gathering experience, and it's not about gathering opinion about what services should be like or what's it. It's about the experience. So, you know, people might phone us up and say, oh, well, X, Y, and Z should happen, this, that, and the other. And then if we say, well, have you used the service? Tell us about that. And sometimes you just have to dig that bit deeper, because it's actual experience that's the important thing, because that is what's happened, and that's the bottom, that's the golden thread, as I say. So we are described as the local health and social care champion, and local is really important in this, because again, by law, each local authority must commission a HealthWatch function. They don't have to commission a particular type of organisation. That's up to the local authority about when they commission what they want to go for. And if you look across England, there's all sorts of different ways that this can be done. So in Northumberland, we're commissioned actually through adult social care, and we're very grateful to the level of support you've been able to continue to give us to do our work. And we are delivered by a local charity called Adapt North East, which is based in Hexham but serves the whole of the county, and actually by its name a bit beyond. But it's a charity that has existed for around 30 years to support and enable people with disabilities or with any sort of help they need to get services, and to make sure that services are there. So the HealthWatch function sits really well with Adapt, because their mission as a charity is basically like what HealthWatch was created to do. So it's fitted really well. So that's where we were created as this champion. So in addition to support from the council, we also get some funding from the NHS as well, but that's around particular project work that they want us to do. So for example, we are working with HealthWatch North Tyneside as well at the moment, working in NSEC in Cramlington in the emergency hospital, talking to people who are using the new front door service. I don't know if anyone's been in there recently, but they've got a new way of triaging you as you go in the door. Really new, really, you know, it's only been probably going about 5-6 months now, but a really new way. And, you know, we were concerned that people were going to understand that. Was it actually going to meet what people were expecting? And so, and I have to say, Northumbria Trust were exactly the same way. So we're just finishing that piece of work now, and it's been mixed. We've had, you know, we've given proper feedback, but it's been a really interesting piece of work. So I've just put that up there because I like the picture more than anything else. But that is what we mean when we say that we champion. We're a health and social care champion. We're just, because I think a lot of what we do in the health world and in social care is driven by data, and sometimes we forget the stories behind the data and the people behind the data, and it's really, really important that those stories are heard. And I think all of the agencies that we work with actually thank us for that, because it does mean that there's a reality to it, it's grounded in reality. So that's what we do. And I think for me, it's the bottom line as well. It's about that we help provide better information for better decisions. And that for me is a really, really important aspect of what we do. So this is who we are. We are six bodies, 4.8 full-time equivalents. We have an office base in Hexham, but we very rarely see our office base because we're always out and about. We have 12 board members. A board member is not a board in like a management committee. It's a board that oversees the project and sets the strategy and basically makes sure that we're delivering what we do and that what we're doing reflects what we're hearing. So very much sort of not letting us go off on private enterprises about saying, oh, well, I want to investigate this. It's no, what are the people of Northumberland saying we need to do? And we have 12 volunteers, and I'll talk a bit more about those later, but that's who we are and what we do. So what have we been doing in the last year? Hopefully you'll see that the annual review shows that we've fulfilled our statutory functions, and I'm obviously happy to answer questions later. But the work that I would particularly highlight is the audiology work, and that shows the importance of tenacity, which I spoke about earlier with the dentistry. We knew, because we were being told, that audiology services that are delivered by Newcastle hospitals in Northumberland were not meeting the needs of people with hearing loss in Northumberland, and we were hearing that from 2019. We produced a report in March 2020, so you can imagine what happened to that. But we picked that up after the pandemic, and we continued to work with the hospitals, and it took 2 or 3 years to actually get real action, and the trust came to this committee with the action plan that they put together with us as a result of that piece of work. And it's just one of those things where I would say that it's not over, because it's an action plan. Yes, we've seen some things, yes, there's been some actions, but the proof of the pudding is going to be what happens next. So I would say all of you in this room had that responsibility to say, if you come across people in your wards and whatever who mention audiology, let us know, because it's a way that we can track whether that plan's actually delivered. The other piece of work that's absolutely stunning piece of work really was around young people's mental health in schools. We have a young student volunteer who has an interest in going into the health service, and he's very concerned about mental health services, as you were talking about earlier, and what his peers knew about what was available. And he basically got a group of sixth formers in the Queen Elizabeth High School in Hexham, and they did a survey with amongst themselves, but with parents as well. And they've written a really good report, which we've literally just published this week, and it's gone to the school, it's with the school, it's with parents, and it sits alongside all of the suite of other information that we've got about mental health services, especially for young people. They helped us redesign our website, and it's a really good piece of work. And I think if you see in the report, Matthew is now waiting for his A-level results, and he says he's talking about the piece of work at his interviews, probably got him the offers from universities that was really nice. So we feel very nice about that. wishing him well for his A-levels. So the other piece of work that we did last year, which was again, it's part of our statutory role. We were given this power by the Act. Well, it actually sits slightly outside the Act, but it's a statutory power to enter and view premises where adult care is being provided, either in a health setting or social care setting. It's not an inspection, it's not the CQC. We are there with a lay perspective, because that's who we are. We are there as patients. We go in there as a service user. So last year we used that power in 4 care homes in Northumberland. We did it with one provider because we wanted to get sort of like a baseline of doing that and just seeing what one provider was doing. And we've just published the final report from that, and I think if you read the reports, you'll see that the care homes found it very useful. We spoke to residents, we spoke to relatives, because they're our main, they're the people that are important in terms of putting our work together. We're starting a new round this year. We've got another 4 homes that we are hoping to visit this year. So we'd always like to do more, but and we've got a good team of volunteers now who I think are raring to do more. But it was a really useful thing, because it gave people the opportunity to say things that they don't. And I've been in this situation personally, so I know this, that sometimes when you've got a relative in a care home, you don't always feel comfortable raising everything you should. You do raise the things because, if like me, you're a gobby daughter, you're going to do it. But other people don't, and I think sometimes it's really difficult to raise it. So saying that to someone else who's on the outside who can then say it, it's really important. So yes, that our enter and view visits. And they're the other things that we did as well. And you can read all about those in the report. So these are just some of the reports, so they're all available. We've got hard copies of some of them. The things I would draw your attention to, particularly as local members, is 2 publications, which is our mental health services, which is in huge demand. In fact, the DWP are always ringing us up for more copies, which it brings together in a really easy format that you can carry around with you. You don't have to have your phone on, your whatever. You can have, all the services that are available. Great for signposting, and I would recommend it to you if you haven't already got copies, and we can send you copies. The other one is our cost of living support in Northumberland, again, which great for signposting to areas of support. So they're slightly outside our sort of evidence reports, but we know that these were things that people were asking us about. So this is what we produced. So that's how you get in contact with us. What I would say is that all of those are used. We get people contacting us through all of those means. I think the ones that, if you've not already signed up, please do through our website to get our our monthly report, which is the one it's the colourful one with the pie charts on it, and that's just a roundup of all of the things that we've heard in the preceding month. We do Here to Hears, because we do love a catchy title, and that's our drop-in services, and we review where they are every so often. So we move around the county, but we have 5 over the course of the month. Some we'd have more standing ones because sometimes, obviously, when you're working with communities, we're asking people quite personal things. So we're asking people to share quite personal things. Now, by and large, people are very happy to tell you what's happened to them when they went to the dentist or when they went to the GP. But some of the other things we're asking is a bit more personal. So we'd like to spend a bit more time getting to know people. But most of the time, there's going to be one near you, and our annual survey is always a good place to put people to. So that's how you get in contact with us. One of the things that I would say is that the other thing that we spend put quite a bit of effort into is our annual meeting. We have an annual meeting every year. This year, for the first time ever, we are holding it in Hexham. We've been all over the place in the last 8 years. We are going to be at the auction mart because we've been doing some work in the auction mart with the farming community, so we're sort of building on that. The local MP, Joe Morris, is coming along to talk at that, but we're also going to be talking about direct payments. So someone from the department's going to come along. I don't know if they've told you that. Is it going to be you yet?
No, but it's fine.
I know it's going to be. I'm just saying that they sort of told you're coming. I don't know. We're happy whoever comes along. But it is this thing about saying we know that was picked up by the CQC from the inspection. What can we do to help you do that? How can we get people to understand and know that this is an option for them? Because it's quite a scary thing. I mean, every time I hear about direct payments, I always think, that takes a lot of thinking about. So we're trying to demystify it get people to understand what it is and just see if that is something for them. If it's not, it's not. And the other thing we're doing is Pharmacy First, because as you're all aware, we've got a pharmacist coming along to talk about Pharmacy First, because that's another big innovation where you can go to a pharmacy before you go to a GP. So it's all part of that story about going to the right place and getting the right service. So what else can you do? Encourage people to volunteer with us, because we're always happy about that. We love having volunteers. The more volunteers we have, the more things that we can do. Our volunteers got loads of roles. Got ones that love going out talking to people. Other ones like reading stuff. Whatever it is, really. But as you say, it's really good for their CV if that's what you want to do. So that's about all I've got to say for the moment. The only other thing that I would say at this stage is about the future. What we're planning to do for this year is we've got a whole plan which you'll see set out in the report. What we're doing this year is that we're doing work around digital access to GPs. We all know that going to the GP now online to book an appointment, how does that actually work for people? We know it's mixed, we get a lot of feedback about that, so we're actually doing some work, trying to work with practices and primary care networks to find out where it's working well and where it's working a little less well, and we know that that's the situation, so we're doing some work around that. We are also looking at dentistry again, because again the dentistry recovery plan is coming out again and is being rehashed, and we need to see actually is it delivering for Northumberland. So that's a piece of work. And in terms of social care, we are looking at respite, because that still keeps coming up, and we've had lots of conversations about that, and we're working with Carers Northumberland, the Carers charity in Northumberland, about that, and probably a bit about discharge as well, about hospital discharge. And again, I think you had that on your presentation as well. So they're the main things, and that is what we're going to do. We are going to continue, because talking about the 10-year plan, the 10-year plan has decided that the Health Watch brand, so the nice logo and the brand, is going to disappear, but the functions of Health Watch, so all the things I've been talking about, are going to continue. They're going to be split between the Integrated Care Board and the local authority. But at the moment, we don't know what that means. We have to be taken off the statute book, so that takes time. So basically, the message I need you, or this is a call to action for you all, the message I need you all to take from today is Health Watch is very much here, is very much continuing to doing what it's doing, until such time I'll tell you otherwise. So I will be back here next year, basically, telling you what we've done in that year. But happy to answer any questions.
Thank you very much, Derry. Does anyone have any questions? Councillor Hunter.
Yes, a couple of questions. There still seems to be a problem with accessing doctor's appointments through digital. Mm-hmm. It's all right if you want to maybe see a physiotherapist or a nurse, but it's a doctor one, that one. And audiology from the Berwick area, we have to still go down to the Freeman. And if you don't drive, it's a train and then getting across Newcastle, which I always say it'd be handy if it was the RVI or that, at least the train, you can easily get there. Yeah. And I think the new hospital's hoping to have audiology in it, but it's a case of, it's that distance, and sometimes people that needs hearing aids can often be the older generation. I know it can go across all generations, but it is often the older people. And I think it's just, as I say, but anything that I pick up, I'll continue to feed in.
That would be so immensely important, because I think the Berwick provision in the new hospital has been one of the questions that we keep asking, and we've not had a final answer to that. And I know, because they still need to do stuff, but yeah, so definitely want to keep on with that one.
Thank you. Because it's one thing, we were having this conversation earlier about, I won't name them, but which GP practice you're getting more feedback. It's harder to get a GP's appointment. And as counsellors and our ears to the ground, we can pick up patterns. So often when you say to officers, isn't it just an isolated, I'm getting lots of complaints about that, and that obviously provides evidence there's an issue here. It's not just a one-off. Councillor Carr?
Thanks, Chair. Thanks for the presentation again, Derry. I'm glad you mentioned signposting, because I'm very much interested to know, in terms of the communication feedback you get from the members of the public. Is that via the website, or the telephone number or the email, because in the digital age, how we're more connected than ever, it always seems to me that there is a generation now who are invisible and are going to be invisible and lost, in my opinion, because simply for the fact that they don't want to be online, and they'd rather, you know, go through a telephone or in person. I actually believe that it's up to members as ourselves or community groups to ensure that the what's considered old-fashioned now, ways of communicating via notice boards, is always available. So in my area of South Beach, I've made sure that I actually have a Health Watch postcard in the notice board, so that the residents who go to the shops in this centralised location can see that, so the information is there for them. And I was just wondering, do you communicate with communities to ensure that the notices such as these, I assume they are in hospitals and GP practices and the rest, but
Libraries.
in libraries, but in terms of notice boards, because again, there are quite a few notice boards I'm aware of throughout Blythe and possibly the wide area of Northumberland as well, that are sat unused, and these actually, I believe, should be utilised more for important pieces of information such as this.
Yeah, no, absolutely agree. And I think that is, and again, I think that is one of the things that we are very acutely aware of. And that is why the hear-to-hear sessions are so important to us, because there is nothing that, you know, apart from sitting across from someone and them telling you, or you grabbing them as they're going shopping. So yeah, we do, and we're happy to send out posters and leaflets and things. So, if, I mean, we did, I remember, I think I had Seg Hill as my, well, Seaton Valley as my area, where I was going out into all the shops and the community centres and whatever, and saying, oh, can you put one of our posters up? But it's something, you're right, that needs to be done very regularly. So getting them out to you as local, because you are our local champions in those communities. And so if you can signpost people to us, and as I say, you know, and Georgina and I have had this conversation many times, is that if you are going to hear stuff we don't hear, absolutely, that's absolutely accept that. But if you can either signpost the individuals to us, or you can talk to us on their behalf, then it sort of bulks it up, and then we can use the levers we've got as well as the levers you've got, and that just starts to be a really good virtuous circle, I think, of influence and getting change.
Does anyone else have anything that you want to ask or say? Neil?
Thank you, Chair. It was just a comment, really. So, the abolition of Health Watch came out of the blue in the 10-year plan. There were some things that were kind of leaked and predicted. I was a bit gobsmacked when that one came out, to be honest. And I think we've invested an awful lot of effort, certainly over the last 5 years in particular, in trying to develop our relationship. I'm really keen that whatever we do going forward, and like you say, we've got to see the small print, Derry, of what comes through in the proposals from government to start with and what ministers have in their minds. But the fact that Health Watch is independent from us as the council, I think is really important. Most of the other types of user interface with clients on the health side are run by Acute Trust and they're run by Health, so there is a vested conflict of interest in there, particularly in a difficult situation. And not dissimilar for us if we take it over as the council and do it. So I think we've really got to get our thinking caps on about what comes next, whenever that is. You know, it might be 2 years down the line or whatever by the time ministers issue the guidance. But I'm really keen on that independence part of it. It's more of a comment than a question, Chair, but I think we do need to think carefully about that. We've benefited a lot from the interaction with Derry and the fact that Derry's not part of us. And you do give us a bit of a hard time. I don't always like what you say to me, but I do appreciate what you say to me, if that makes sense. So, yeah.
It's a mutual thing, isn't it?
Yeah.
I mean, the Adult Social Care Panel, which you mentioned, is something which I think is just proves how well it can work. So we've got a panel of people who use services, or are carers of people who use services, and we meet, as Neil said, and it's the granular detail that you get back from someone who's actually living that experience. It's priceless, but again, they're independent. They're you know, they come through us. That's fine. That we're independent.
Nobody else anything? Well, thanks very much, Derry. And I think it's important to encourage residents, because you'll get lots of complaints about can't get a GP's appointment, have to travel, etc., and feed into Health Watch. So even if you're dealing with that piece of casework or contacting directors, I always say contact Health Watch as well, because it just adds to that picture and adds to your case as well, how many people are contacting you, because you want that number to go up. Just before we move on to the reports, just a quick one. Councillor Green said that he did give his apologies. Now, what I suspect is happening is when people are getting a calendar invite, they're saying no, and they think that means they've given their apologies, when really you meant to email separately. So I wonder if we could check, just for the purposes of apologies, so if we add Councillor Green for giving apologies, and there's one remaining member, wasn't there? Councillor Oakley, she did that as well, and maybe just send an email to that doesn't count as apology. If you get a calendar invitation and you just say no, yes, or maybe, you have to just separately email in your apologies to get that noted. Could that just be communicated to the whole council somehow? Because I suspect people are thinking that means they're giving an apology. We don't want people to think they're giving an apology and look as if they've not turned up or bothered to give the turn, to be fair to them as well. Now we move to reports of the scrutiny officer, and I just want to emphasise that sometimes this could be seen, these last items, that are obviously a lot shorter items than the substantive items, but they're sometimes seen as a bit of an afterthought, like time of the next meeting, start packing up. These are really, really important. This is your opportunity to feed in our work programme and what we're going to be scrutinising, and the whole point of what we're doing is to improve decision making. And so this is a really good opportunity to have a think, come back later, you can email at a later time ideas that you have for things to be scrutinised. So over to my fantastic officer.
Thank you, Chair. Yeah, it's just to highlight to members that the forward plan, it contains all the recent decisions that have been taken by Cabinet, and it will also show you all the business that is scheduled for the next future Cabinet meetings. So if there's anything that falls in our remit that is of interest to you, that you want to be scrutinised, you can pick them out of the forward plan. And also, I'll just move straight onto the work programme, if that's all right, Chair. Yeah. So the work programme, that shows you what the committee is going to look at. It's a working document, so it gets added to all the time. And it's just to say that the work programme belongs to the committee. So as the Chair says, if you have anything that you want to raise, please do contact myself or the Chair, and we'll try and get it onto the work programme if we can. And the monitoring report that's attached to the work programme, that shows you what we looked at last year. So what I'll do as well, I've got a couple of updates for the work programme, just some verbal ones since it's been published. In September, we're hoping to have a public health overview, similar to what Neil's done for the adult services, but for the public health service, so we can kind of see what's coming up and what that service covers. In November, we've got the North East Ambulance Service will be joining us to discuss patient transport. And in January, we're hoping to look at the Heart of Blythe project as well. And could I just get the clicker off you, Andrea? What I'll do is I'll just quickly go through the presentation that was attached to the agenda. So that just gives an overview of what we looked at last year and kind of gives you a flavour of what we look at as a committee. So last May, we covered the community water fluoridation. So it looked at the new community water fluoridation consultation, which was led by the Department of Health and Social Care, and it gave an overview of what we will be getting through the water fluoridation. In April and May meetings, we tend to get a lot of quality accounts as well. So we received quality accounts from both Cumbria, Northumberland Tyne and Wear NHS Foundation Trust and Newcastle Hospital NHS Foundation Trust, and they give you kind of a review of their performance as well as their next year's priorities. In September, we had a report from our defibrillator task and finish groups. So task and finish groups are a tool that our committee can use to deep dive anything. So if there's any topics that we cover that you think we need to look at in further detail, with the agreement of the committee, we can create a task and finish group and look at that in more detail. We had an adult services conversation position statement, which gave an open and honest conversation about the current state of adult social care, and looked at kind of the pressures of our services. And then we also received our Health Watch Northumberland annual report, which we've received today. In November, from members' requests, we looked at NHS GP access. So we got colleagues from the ICB and GP doctors to attend to kind of give an overview of general practice services and the pressures that they kind of faced. And we also had an annual report from the Adult Social Care and Continuing Healthcare Services. In March, we had a North East Ambulance Service performance review, which was also at a member's request. So if members bring us things, we try and get them on the work programme in a timely fashion. So that gave us information on performance of the NIAS and any pressures that they had. And as Derry mentioned, we also had the audiology services. So the Director of Operations in Newcastle Hospital came and gave an update on audiology and gave us how they were going to improve their work. And in April, we received another quality accounts from Northumbria Healthcare, and we got an annual report from the Director of Public Health. So that was just a quick whistle-stop tour of what we covered last year to kind of give you a flavour of what we cover in the committee. And if you are enthralled by all of that, the reports and minutes are on ModGov on the Northumberland website, and you can even go and watch the meetings if you so wish on the YouTube. Thank you.
Great. Just a couple of things. Obviously, the forward plan, there's less decisions that made that would be relevant to this committee than some of them. I mean, we predominantly looking at National Health Service. Before I open it to the floor, just I've asked, and sometimes when we're looking at things, it can be a seed that we're growing, so we've not got to define what we're looking at. But I did ask earlier, I'd like to see something around house, and how linked between house, issues around overcrowding and so on, and health. So that's sort of a work that we're going to look at, what we could look at, because I think that would be very worthwhile. There's also been a request to look at the Heart of Blythe project. Do you want to say something about that?
Just that we have it scheduled for January, so they'll be coming in January to discuss the project that was delivered.
Great. Now, does anyone have any questions, any requests on the work? Like, this is what we're looking at in for the plan. Any questions? What's currently on that, or any ideas, requests for the future programme? We'll have a think. Speak to your colleagues. Oh, Neil has, yes.
I know I'm not a committee member, but just in terms of that level of change that's happening in the NHS, if I was a committee member, I think maybe bringing the ICB to talk about the impact of taking a third out of your running cost budgets and how that will interact with other parts of the NHS and with the local authority may be a useful presentation for committee, because I don't know the full impact at the minute sitting here as the Director of Adult Services, and I'm nervous about it, I have to say. So I'd just offer it as a suggestion. But
I mean, the whole part, obviously, we've got the way, but taking suggestions from anyone, and obviously particularly that, and I think we'd all agree that would be very worthwhile. Yeah, everyone's nodding their head, so yes, please. Yeah, thanks for that.
We're still working.
So next item is urgent business, which there is none that have been informed before the meeting. I've got a scheduled date of future meetings. There's a slight error. The 2nd of May is a Saturday, so we're not going to bring everyone in, much as we all enjoy this committee. I think that must be the 5th. It's the 5th instead of the 2nd. And the next meeting is scheduled at 1 o'clock on the 2nd of September. Is that right? So I will now close the meeting. Thank you very much, everyone.